Well, good morning, everyone, and welcome to our latest installment of Conviction and Conversation in Contested Times. This morning's topic into the afternoon is related to healthcare as part of this series. I'm Andrew Finstuen. I'm the Dean of the Honors College here at Boise State, and I'll be moderating the conversation. Before we begin, I have a few announcements to make. First off, we've gathered a number of audience questions in advance. Thank you for submitting those. And I've done my best to integrate them on some of our pre-planned questions for today's panelists. Second, this webinar is being recorded and will be hosted on our website under the President's initiative of this conversation series. I think a chat will be, or the link will be sent to you all in a chat, so you can follow up with this conversation at a later date as well, as it is being recorded. I'd also like to recognize President Trump, who launched this series of conversations last fall to encourage and model conversations on complex issues. And I'd also like to thank Dean Tim Dunnigan and the College of Health Sciences. Dean Dunnigan was instrumental in the planning for today's events. And of course, the college's faculty and staff are deeply engaged in training practitioners and future health leaders. And today we do that. We gather healthcare leaders from our Treasure Valley to discuss issues facing healthcare locally and nationally. We're grateful for their willingness to spend time with us today. And of course, we're grateful for what they represent. So many dedicated professionals in healthcare: the nurses, the doctors, the technicians, the sanitation crews, the administrators, the medical social workers, the pharmacists, the many therapists from respiratory to radiation, and so many more who work for our health and well-being. I am particularly grateful for two reasons. My mother was a nurse and a healthcare administrator for nearly 40 years, so I grew up with a sense of this work. And second, I'm grateful because I faint at the sight of blood, so I'm grateful for those who don't. And all of us share in gratitude for the Herculean efforts the medical community has undertaken during the pandemic. Thank you. And thank you to our panelists, who I will now briefly introduce. They bring vast experience in public health, health insurance, hospital administration, and the practice of medicine. Odette Bolano is the president and CEO at St. Alphonsus Health System, a 610-bed 4-hospital system serving Idaho and Oregon. Odette began her career as a nurse after receiving her Bachelor of Science in Nursing from Texas Christian University. She earned her Master's in Administration of Healthcare Services from the University of Houston at Clear Lake. She serves on several national and local boards, including Boise State University's Foundation Board and Boise State University College of Health Sciences Board of Ambassadors. She has been named one of the top 50 healthcare executives in 2020 and a top 25 women leaders in 2021. Dave Jepson is the director of the Idaho Department of Health and Welfare. Dave is a native Idahoan, born in Burley, Idaho, and raised in Amen, and where he graduated also from Idaho State University with a degree in mathematics. He has worked in banking and health insurance before being appointed to Governor Little's cabinet as the Director of Health and Welfare in January 2019. He's married with 4 children and 3 grandchildren, and he enjoys the outdoors, hiking and skiing here in the great state of Idaho. Dave Self is the Chief Administrative Officer at St. Luke's Health System. He began his career in healthcare in 1989 with what is now Regents Blue Shield of Idaho, eventually serving as Vice President of Sales and Marketing for Regents Idaho and Utah. From Regents, he joined software companies to build healthcare practices, and in 2006 joined Primary Health, becoming President and Chief Operating Officer. After selling the company to Pacific Source Health Plans, he served as Senior Vice President with Pacific Source until joining St. Luke's Health System in 2014, where he currently serves as Senior Vice President and Chief Administrative Officer. Dr. Rhonda Robinson Beal is a senior executive physician and a healthcare executive with over 30 years of experience in healthcare systems, managed care and quality improvement, and behavioral health and medical care. She has served in the past as Senior Vice President and Chief Medical Officer for several large national and local healthcare organizations, and has been involved with many national organizations as a subject matter expert including National Institutes of Health, Institute of Medicine, and the National Quality Forum, among others. Dick Armstrong is the former director of the Idaho Department of Health and Welfare. Dick served in that role for 11 years under Governors Risch and Otter. Prior to his 2006 appointment, he was employed by Blue Cross of Idaho for 37 years, retiring as Senior Vice President of Sales and Marketing, developing the first PPO and HMO products offered in Idaho. And we're so thankful and pleased to have such a distinguished group of panelists join us today. I have one more little brief introduction here about the topic, and we'll dive right in. American healthcare spending accounts for $3.8 trillion, or nearly 18% of gross domestic product. The scale of that spending has implications for our wallets, averaging more than $11,000 per person per year, and more importantly, for our well-being. So with so much at stake, we're eager to hear from our experts today, and I'd like to start with Dick Armstrong on the first question. What is your estimation of how healthcare is delivered and how it might be improved? Thank you, Dick.
Thank you. Thank you for the opportunity to join this group. The United States has a unique mix of private insurance and public spending for healthcare in our nation. It's estimated about 70% of the dollars spent really are from some government source, be it Medicare, Medicaid, state governments, local governments, federal employee programs, et cetera. So we already have a significant amount of government money coming in the system. We also hold politically to a private insurance industry, and that is where some of the confusion occurs, because a lot of folks don't really separate private insurance from public health. And public health is a very different vehicle, very different animal from health insurance. But over the decades, the public, in their desire to have insurance pay for wellness, have changed the concept a bit to where private health insurance is spending more and more money on wellness issues, mental health, and other long-term, non-unique episode of events. So as I see this, it will continue to evolve. And recently, especially through the pandemic, we saw where certain types of reimbursement methods with health systems became an advantage to the health system. These were value-based payments. In other words, fixed reimbursement per month for a member. What, of course, we saw was that those that had higher volumes of cash flow coming from those fixed reimbursements, as opposed to fee for service, there was an advantage because they were getting the cash flow when through the pandemic, all of the elective procedures were discontinued for the most part, which greatly reduced revenue to health systems and to providers. So that told us a little bit about the vulnerability of fee for service. It also told us that having these global payments actually moved the agenda towards population health or wellness. In other words, a blending of a public health delivery method with a private industry. So I do think it's going to continue on evolving.
So thank you, Dick. That's a helpful overview on the notion of healthcare delivery and how it might be improved and kind of continuum of issues that you've raised there. And I wonder, first Odette, and then to you, Dave Self, to think about it from the system that you're both running in terms of St. Alphonsus and St. Luke's, to comment on that, given the frame that Dick's just offered.
Yeah, thank you so much. Thank you for having me on your panel. So I think that this has been a question that we've been grappling with for a very long time, right? And I think you all have been hearing about population health, and we've all heard the statement, tell me your zip code and I'll tell you your life expectancy, right? So we know that in our ability to have a healthier society in the United States, we really need to focus on wellness and prevention. And our systems, as they evolved over the last 100 years, medicine and how we deliver healthcare, it's all been incentivized on sick care. We only have spent money until recently on providing care when people have a problem, and we haven't funded public health. I think we'll get into that later in the manner that we need to. And so it has incentivized a very fee-for-service focus on only get healthcare when you have a crisis or a problem. And we need to move further upstream in ensuring that we're focused on wellness prevention, which means that we have to change the way that we pay for the services, right? The reason we haven't focused on them is because there hasn't been a financial incentive, unfortunately, to ensure that we're focused on that. We when we look at our life expectancy in the United States, first of all, it's dropped a full year, first time since World War II, because of the pandemic. And I think that that speaks volumes about how we're focused really in chronic care versus wellness and prevention. But we also, when we look at that, we know that we are only focused on getting people into our systems when they're sick. And that mentality and that focus from the public has to change also. So we are all working with, as you noted, Andrew, we have public and private healthcare, which is very different than what we see in other countries. But when we look at life expectancy across other developed countries, we can see that the spending on prevention and wellness is significantly more, and public health significantly more than what we have. And so that, shows us that there is a correlation between those two. And I think that, the expectation of how we've built our systems where personally, again, these things are starting to change. I was more dependent on my employer picking up the cost of my insurance, and therefore had very little visibility or interest in what the costs were. I think that is all changing as we move forward in how we deliver healthcare. So those are just a couple of key points on what I believe will continue to move the dial.
Thanks, Dave. Self.
Thanks, Andrew. A privilege to be here today. And building on what Dick and Odette began the conversation with, the delivery of healthcare itself can be quite efficient. And maybe a different consideration is how is healthcare accessed? Some of the things that Odette pointed out are key and central to how we should be thinking about it. We don't have to be another country with a different system of delivery to think this way. And the question of how is healthcare accessed really begins to touch on a number of areas, including accessibility, affordability, and those two dynamics are connected. If you can't afford care, accessing it can change dramatically. Other considerations include equity of healthcare, necessity of healthcare. Think of pharma advertising and the demand that it creates. And to a point that Odette touched on, how is healthcare designed? Is it designed to be sick care, or is it designed to align the incentives between the consumer before they're ever a patient, the individual providing care, and how care is paid for? Where those incentives come together in the concept of value-based care is really how we've been able to mature the system probably in the healthiest way that it has for the last 20 or 30 years. And if you really step way back to 1917, when a group of timber workers in Pierce County, Washington got together and asked their employer to pool some money from them and pay some local doctors a fixed amount to take care of them no matter what happened. By the way, that became the first Blue Plan in the United States, and was a genesis of the Regents Group as well. That really was a coming together and focusing on quality and care, and it had a lot less to do with how many ticks through the meter there were to get paid, and more about the health of that very defined population. So those are some of the considerations that might be interesting to think about.
I would add something, if you don't mind, to what Dave said. So, if we look at, I mean, we all get our bills for our healthcare providers and we hardly understand how to read them, right? And so it's really complex, right? And fraud and abuse has led to such incredible administrative burdens that all raise the cost of care. So a study that was done in 2018, what they shared is the amount of administrative burden on healthcare systems for how you bill, how you manage healthcare was $265 billion, which equates to more cost than what we know is tied to fraud and also to overpricing. So if you just kind of digest that, and I think that, the burden that we've created really is another area where we have to continually focus on as we redesign healthcare, how we get rid of some of those administrative burdens.
Yeah, thank you. And so we're well into it already. Design, values-based, fee-for-service. But what the two big themes that I'm hearing from all the panelists so far, and I'd like Dr. Rhonda Robinson-Beal's perspective, and then Dave Jepson, is I've heard two big words: access and cost. And I'm wondering if, based on both of your experiences across healthcare and Dave Jepson in the public health sector, to talk a little bit. So Dr. Robinson-Beal first on access and cost, your perspective there, and then over to you, Dave Jepson.
Sure. Thank you. I also want to thank you for the opportunity to be here. So you're absolutely right. Odette and Dave are quite right. Access is linked to cost. If you can't afford it, you can't access unless you're going into a public health system, of which we have here in Idaho and other states. But still, that's very limited in terms of what the scope of services that can be given. I will say that access is exceptionally important. However, access can be improved with the way the system is funded. So I said I've been around for 35 years. I really have. So I was around when what I would say the first wave of capitated arrangements were put in play in the 1980s. I happened to be very lucky to be assigned, or maybe I thought I wasn't so lucky then, a full capitated population, 44,000 members. They were commercial and Medicaid. And I had the responsibility of setting up the network as well as delivering the care to these individuals. And I learned that care can be different. I'm a psychiatrist by background, so theoretically I would practice the Freud model in terms of 45 minutes with each patient. I learned that that was not the way to deliver care. You have to deal with where the patient is at. And so the most important factors were access to care, quick access to care. So 24 hours a day, 7 days a week, my practice had to be available for my patients. By being available, we were able to avert the crisis that came up and begin to deal with individuals without them having to go into the hospital to seek a safe haven in some way to deal with those issues. We also learned that frequent contact with patients, because we are now accountable, we do not let them fall through the cracks. So if they didn't show up to the office, we were there to contact them by telephone. We didn't have audio visual then, so it was a lot of telephone work in order to keep patients engaged, because as a provider, my role is now different. I'm getting paid, but I'm getting paid to keep people healthy. So therefore, I'm not waiting till they're sick and coming to my office. I'm reaching actively out to them to help avert any problems, but also to keep them stabilized and keep working. Also learned through that there was a lot of education that was needed of patients who are seeking healthcare. There was at that time, and not so different now, the philosophy is, doctor, you cure me, I don't do anything about it. Well, I learned I had to change that dynamic into patient, let me help teach you some of the things that you can do to help maintain your health and also to help you to become healthier. And the more that we put into that with messaging, with peers and other interventions back then, because we don't have all of them that we have now, the more powerful that it is. Moving to today, especially with the pandemic and for behavioral health, this has touched everybody. This has been a pandemic where everyone has experienced some type of emotional change or a burden from this. What we're learning is that telehealth is now here to stay. Where people were hesitant to use it before, they're using it by large numbers, not only in terms of audio visual, but also just a phone call and also a reach out by text or any other type of asynchronous type of communication. What we're finding, the more often we are able to communicate with individuals, get them engaged and teach them and help them understand and reinforce those new behaviors, the better off that population is. We have seen tremendous increases in some of the factors that are used in behavioral health, the DAS, the PHQ-9, and other types of scales have really shot up quite a bit in terms of using these modalities. So access, frequent access, and being able to teach and help reinforce behavior change and empowerment on the part of our patients who are now our members in some way and is a part of our healthcare system.
Yeah, and thank you for that. And to put a little spin on the access piece for you, Dave Jepson, especially in your role with Idaho Department of Health and Welfare, access in rural communities as well. If you could speak a little bit about that, and others can speak to it too, but that's a theme that comes up based on your comments, Dr. Robinson-Beal.
Well, thank you, Andrew. And again, thank you for the opportunity to be here on this distinguished panel of colleagues and friends that I've worked with for several years now. And you should actually circle back to Dr. Rhonda Robinson-Beal on this question as well, as she is an expert in rural health access and has spent much of her career actually working on that. But certainly that is one of the challenges that we see in Idaho. There's a metric that is used at the federal level that measures healthcare access for both physical health or medical health as well as behavioral health. And it measures how many of your counties have what would be considered an adequate number of healthcare providers, both medical and behavioral health wise, to meet the needs of the community. Idaho has 44 counties. Only a handful of those counties meet the metric to have enough medical professional help available to provide the needs for the community. And that's typically in your urban counties, not your rural counties. And then all 100 or 100%, we don't have 100 counties, 100%, 44 counties do not meet the benchmark for behavioral health access. And so it's acutely felt in these rural settings. And Idaho is very rural. For those of you that have traveled the states, it's a mostly rural state. And so what we have seen that's been a problem to date. There's been lots of focus on that. It creates access problems. You have critical access hospitals that operate in those rural areas that are on the verge of financial viability, which would be catastrophic if they closed for those communities. You have pharmacies in those rural areas that are the lifeblood of making sure we have good health in those communities. The data says if a local pharmacy closes in a rural community, it's a large negative impact to health because then they lose access to their pharmaceutical needs. So obviously there's mail-in needs, but there's those that they go to get directly. And so it's pretty critical. I think the thing that's really turned the corner, and Dr. Robinson-Beal mentioned it here in just a moment ago, is through the pandemic, if there were any silver linings, one was the widespread adoption of telehealth. And particularly in the rural communities, that's been a real big boon in terms of access. Including in the pharmacies. There's telepharmacies now in rural communities. The state has made more investment using some of the CARES Act, the Coronavirus Act money to increase broadband access in these rural communities. And it's not the be all end all. It's not going to solve every access issue, but it has dramatically improved access in our rural communities. In the first days of the pandemic, we saw the use of telehealth jump almost 40,000 times. I mean, 40,000%. It was massive, from a couple hundred to tens of thousands of telehealth visits. And I think that's been a really important step forward. And so lots more work to do with access in rural Idaho. But we've actually seen some improvement in the last 12 months, oddly, driven by the pandemic.
Well, I think maybe we should circle back to your suggestion, Dave Jepson, Dr. Robinson Beal, given that you have that expertise to maybe comment further, and then Dick Armstrong picking up on this theme of access and cost as well.
Sure, thank you. So one of the things I had the pleasure of doing was really doing a deep dive into the counties here in Idaho, looking at rural health and how it's delivered. And one of the things, there's several things that I learned in doing that, but one of the most important things that I learned is that individuals in the communities really want to be involved in their own health care. They recognize that they may have to go to a larger area or urban area to get some of the care that they need, but they want to have some input or some role in that health care. I also learned that some very interesting statistics. So for example, in some of the rural communities, I don't know if it's an access problem or if it's a cultural problem. So let me give one statistic. We looked at the prevalence of prostate cancer, for example, in several of the counties. But when we looked at the death rate from prostate cancer, in the counties, the prevalence was about the same, but the death rate was twice as high. So what does that mean? Does that mean there's an access problem? Or is there a cultural issue going on in terms of not following through once a diagnosis has been made? So it really, when we sat down and talked to many leaders in several communities, they talked about wanting to have some input or having some say, not say, but integration into the healthcare system. So one of the things that we talked about was what's called the last mile. NIH is now starting to fund some of this. It's active in countries outside of the United States, India, as well as Africa, where actually what they do is they set up the healthcare system, particularly in these very rural areas where healthcare is not available, and begin to develop what's called a system of the people practice to the height of their licensure. So what you have are many community leaders who are engaged as temporary screeners of, I would say, common conditions, and they work collaboratively with nurses, PAs, and doctors in more urban areas as a team, and they become accountable for screening and also making sure that people are following up on their health care. And this has been found to be pretty helpful in these areas. And I often wonder whether or not this could be of some help here in Idaho. When we talked to many of the community leaders, they felt that that was a start, but they felt that they didn't really have the resources to really get that together. I know that some of the hospital systems have done some of this in terms of having rural community clinics, as well as their providers practicing in the rural areas, even though they're still a part of a larger area, a larger system. I think it's that branching into the rural areas and developing those partnerships, but also developing the lay persons in those areas to be a part of the system could help us, because we're just not going to get anytime soon enough doctors, enough nurses to supply the care in these areas.
Thank you for that. And Dick Armstrong, I wonder if we might put a spin on the access and cost around, because Dave Jepson mentioned pharmacies as well in rural communities and elsewhere, but also our audience is concerned about prescription drug costs. So in this larger theme of access and cost, access to then prescription drugs and cost, is that something that you could offer some perspective on in your experience?
One of the issues that always concerns the insurance industry is whenever there is a change in delivery or which is either the frequency of the services delivered and the cost of those services, because it's the combination that is multiplied to reflect healthcare expense or and the impact on premiums. So as we look at telehealth and we look at rural delivery, there's have been a historic resistance to really do anything about allowing real utilization of telehealth. And that was because there was a belief that it would not reduce the cost of healthcare. That all it would do would be add another layer of cost, and therefore prices will go up because of that increased an additional layer of utilization. But what we've seen is that it hasn't happened. There is the utilization of telehealth, the utilization of pharmacy outreach. I mean, most of us have experienced that. You know, I'm in a Medicare Advantage plan, which of course encourages that kind of behavior, but talking to others who are not in those systems of insurance delivery, they've seen it as well, the outreach, and that it has not resulted in an increased spike in utilization. Now, obviously, it's all been a bit confused by the fact that we've had inpatient utilization drop, and because of in-person delivery has dropped. And so we are on this cliff right now where everyone's wondering, okay, is there pent-up demand? Is that pent-up demand going to actually materialize in a real spike of utilization? My view is that it really isn't going to show up because individuals, when they couldn't have in-care or face-to-face delivery, have found other ways of getting their health care. And the health systems have been quick to respond to it, i.e. the conversation about telehealth. So the outreach has been done and the therapies have been delivered differently than we've had in the past. And as others have mentioned, they're not going to go back. In other words, people have found this delivery method to be very convenient, to be very effective and satisfying, and that they would just as soon continue that. So in one way, this has been kind of a watershed event in that we have been forced into doing something that we've talked about but not done in the past. And now it's here. So the system is adapting to it. As others have mentioned, it is of real help to rural Idaho, to the smaller communities where you simply will never have a high delivery or high volume of specialty care in that community because they just simply can't support it. But we now have a tool that will allow that specialty care to be delivered via the primary care providers that are there. The PAs and others who are in that community now have these new tools, which is pretty exciting.
Well, and I'm struck by the number of times mentioning telehealth and the way that the pandemic has accelerated that. And here we're having a telepanel on telehealth in a way, right? I mean, it's just the whole piece comes together. Dave Self and Odette Bolano, I'd like to actually shift the conversation a little bit toward how your systems, starting with you, Dave Self, are thinking about handling the mental health concerns that are very much in the news, both from all of us, as Dr. Robinson Beal said, we've all experienced some emotional change as part of this pandemic experience, and then maybe even commenting on the mental health challenges that employees in the health system are facing, given how hard everyone has worked to in the public in health to help us manage this pandemic. So Dave Self, your thoughts on the mental health situation at the moment?
Certainly. Let's start with the concern that I know Odette and her team share with the St. Luke's team. We're extraordinarily concerned about the team members. They have been, pick your favorite phrase, in the trenches on the front line day after day. And it's pretty disheartening for a caregiver to work a long shift, 12 hours, say, maybe 4 consecutive days, and walking out, see signs and or hear comments or see people not adhering to some really basic things. And there's nothing political about this. It's science. And we're willing to rely on science for a lot of areas of our life. But when it came to this and it was inconvenient, well, gosh, we had a different perspective. Well, that hit the care providers pretty hard. And when someone is in a clinic or at the bedside with someone taking care of a very, very, very ill individual, someone who may even die, and they walk out and see that. After a while, those little pebbles, one at a time, get to be a pretty heavy load. So we're very focused on that now. We have a number of different programs, both clinical and practical, that we're putting in place and have been in place to try to support the folks that are doing the work. And that translates well to the patient population as well. Everyone knows that follows healthcare that mental health can manifest itself as physical health. So if you are depressed, if you're carrying a load that you feel you can't carry alone over a long period of time, it can influence how you feel physically. And so it's this vicious cycle that we are trying to break. It's difficult to do today, but we do see some bright lights. The team has our staff that are focused on behavioral health specifically are finding innovative ways to connect with folks, not just telehealth, virtual health, but in the virtual care world, giving individuals tools that they can use on their own. And so Dr. Robinson Beal is certainly an expert in this area, but the more tools, as I believe she mentioned earlier, it's the education and the tools. We find most people love to learn. They don't like to be taught. So we're finding that balance of providing opportunity as opposed to standing on a soapbox and trying to tell people what to do.
Odette, your thought. Thank you, David. Your thoughts on this question of mental health, both from your own teams, but also out there in the public at large.
Yeah, so I'll start with the public at large and then come back to our colleagues. So, I think that many of us have seen articles and studies that are showing that mental health is now the next pandemic, right? For a myriad of issues of why we've been through what we've been through. And if we look at suicide rates against other developed countries, the average for other developed countries on suicide is 11.3 per 100,000. For the United States, it's 13.9 per 100,000. So we clearly, I think that we clearly have a bigger problem. Although any suicide in any country obviously is a disaster that each society needs to deal with. But it talks, I think, volumes about the stigma around mental health in our society. And I think that's something that we're all trying to, the brain is like any other organ, and we shouldn't be ashamed of, an illness that is created, and that we start removing that stigma. I think and it all has to do with funding, right? Do we have enough? How does our public health system support mental health? How do we as providers support? And in our clinics like St. Luke's and others, we are trying to focus on developing of that multidisciplinary team, right? We're asking key questions when you come to your primary care physician, so we can identify whether or not there's a conversation to be had with that patient about how else do we provide support, not just for the physical illness that they're there for, but that we're assessing the dynamics, the social dynamics, the support systems, certain feelings that they're having. I think we are, even though we see real optimism of where we are, and I would just plug that we can't stop the vigilance that we have around safety precautions right now as we're trying to get through that final dark tunnel, right, to the bright light of post-pandemic. I would say that the effects on our caregivers, we will continue to experience what those are over the next 12 to 24 months. As we talked about access, and even in rural areas and not enough physicians, primary care physicians in the state of Idaho, we are seeing across the country, people are leaving healthcare because of their experience during COVID. And so those are, we already had a nursing shortage that we were preparing for, prior to COVID. And I think that COVID will exacerbate what we're seeing. And so a lot of work to be done. The colleague care programs that we all have, the conversations that we're having with our colleagues to support them, as Dave noted, we'll continue on. And I do want to recognize the community has been very generous in acknowledging and providing respite and, just even gifts of acknowledgement to our staff in order to just take the edge off of what they've been through. So we will continue with those programs. We will continue to assess how we support our colleagues and other frontline workers, such as police and EMS and paramedics, so many other people that are at the front line, grocery store workers, right, that have felt a lot of pain during this time. But it is going to exacerbate the mental health issues in our communities, and we need to be prepared to continue to address them.
Yeah, thanks very much. And I can't help but turn back to Dr. Robinson Beal, who we know has expertise and background in this, to think about your comments on the mental health situation we're facing right now.
Sure. So as I said before, the pandemic has really helped, unfortunately, has affected almost everyone. I don't think anyone has been unscathed by the effect of the lockdowns, the illness, the deaths that have occurred, either whether they felt it personally in their own family or knowing others that have died. Also with our children who have been out of school, and we're seeing more and more where that has affected them tremendously, and even there's been an increase in suicide amongst those individuals. It's very interesting to note when we look at some of the stats, generally when we look at the incidence of diagnosis of mental illness, worked with health plans for over 20 years, usually see between the ages of 44 up to around 54, that's where you see your peak in terms of diagnosis of mental illness. That's changed now. What we're seeing now, the millennials, the Gen X and the Gen Ys are starting to demonstrate, and this was even before the pandemic, a prevalence of mental illness, anxiety, and depression. What we're thinking that this is due to was the fact that these individuals are feeling less empowered, less, how would you say, empowered and engaged in some way. Many of them are strapped with huge responsibilities, student loans and other types of things that have been very difficult for them to surpass. But we're seeing a higher prevalence of mental illness, but also chronic illnesses starting at these younger ages. So this is a very important issue that we all need to address. One of the things that we know that we'll never have enough mental health providers to do what I call the traditional type of mental health interventions. So we have to be more creative. Telehealth has helped tremendously, but also expanding that to the primary care, but also expanding that to other individuals to be engaged. We're using peers quite a bit to be engaged and to help engage others. One of the biggest things that's really has boomed quite a bit is the use of digital health. There are many opportunities out there through vendors that are offering digital mental health, primarily from the standpoint of view of CBT, self-guided, as well as assessments, also virtual community support, just like we're meeting with one another through a Zoom. They have actual communities of individuals that have similar types of problems. So single mothers who are handling children. Healthcare workers is another large community that has a virtual community where they get on board and they're able to talk with one another, support one another. The other is just a simple teaching of new habits, sleeping habits, also in terms of how to meditate, how to take your time, and when you leave your job, actually leave your job. Don't take it back home with you, because otherwise you start really not allowing your brain to really relax. Sleeping habits, making sure you have the same sleep pattern every day, because if you don't, you're really disturbing your brain and you become more likely to feel fatigue, as well as not being able to function as well. Getting up in the morning, now this is going to sound strange, but to set your circadian rhythm. Walk outside, no glasses or anything, and just let your eyelids take in the sun, because that helps set the brain, the glands in your brain that sets that circadian rhythm. And then by coupling that with going to bed at the same time, that helps a great deal. So what I'm saying, there's a lot of things that we're going to have to do ourselves. There's also, we're going to have to do it differently than we have in the past in order to deal with this. Public health campaigns are very, very important. There's been a series of those run here in Idaho during the news time, talking about various mental health issues, strain at work, overburden, burnout, all those types of things. So the more we're doing this in the open and the more we give suggestions, the more people are feeling more comfortable being able to talk about it, which helps reduce that stigma, which Odette talked about, which really serves as a barrier to actually really acknowledging what you're feeling and then doing something about it.
Thank you so much. And we've noted some comments and questions around, especially on the campuses. And you mentioned Gen Y, Gen Z suffering from an increasing sense of anxiety and depression. And it's very much on the minds of our audience. Thank you for those comments. I want to shift from mental welfare to economic welfare and have Dave Jepson's and then Dick Armstrong's thoughts around this real challenge that we faced over the last 9-10 months about how do we balance public health and economic welfare, economic health. It's not an easy prospect to be sure, but here, interested in your thoughts, Dave Jepson and then Dick Armstrong.
Thank you, Andrew. That's an excellent topic. And the short answer is they are inextricably linked and move together. And so what I mean by that is if you have good, healthy individuals, that leads to good, strong, healthy economies. But when you have individuals that are not healthy, whether that's because of a pandemic or some other reason, that impacts their ability to participate in the economy, either from their ability to work or go to work or to participate in the normal way that they would in the economy. And so I think there's a bit of what I would call a false narrative out there that you have to pick one or the other. And I would say that's a false assumption. And actually they move together. Now they may not move together at the same time, but they are very close to the same time. They will move together indeed. And so I actually think they are inextricably linked. And I do not know how you have a healthy economy without good public health and healthy people, and vice versa. It's pretty closely correlated.
Thank you, Dick.
Yeah, this period of time we're in right now may be the first time that public health was actually politicized. In the past, it really never was. Public health moved at its own cadence, dealing with issues, broad-based issues. In the early days, sanitation was one of the major challenges for public health and moving forward. But today, this notion that that the good of all is at the expense of the liberties of some has really put a major kink in how you deliver public health, and it's unfortunate because we're going to see it play out over the next few weeks and months. Unfortunately, funding of public health has always been inadequate. Clearly, it has. But what we're seeing is the downside of a pandemic that of course, we've never seen before. We've seen smaller ones, but they never ever reached this magnitude. And so, I would expect that there will be attempts to increase public health spending, but it's going to be an uphill battle politically because we've just gotten some very bad attitudes and anxieties and fears over what it takes to move a public health agenda, and I'm fearful of the future here. But we do know that worldwide, this has had monstrous impacts on the economies of nations throughout the world, and they're all dealing with somewhat of the same problems. It just seems in the U.S. that we are having more of a pushback than we've seen in other nations that are democracies.
I'd like to open. We've got about 9 minutes, but Odette or Dave Self or Dr. Robinson Beal on that question of public health, economic health. Any thoughts from any of you before we turn to another topic?
I would just quickly say, since 2008, we've lost 40,000 jobs in public health across the country, right? So you just extrapolate that. And I think, as Dick noted, the pandemic has shown where we have significant cracks. And I would say that respectfully that, healthcare systems have had to pick up some of what we would all traditionally believe are public health responsibilities. And that's taxing. We have our own, issues that we have to deal with and provide for the community. And, some of this is significant distractions for health systems across the country. I mean, I'm not just talking about Idaho. And I think that, it's not when, it's not if, it's when the next pandemic comes, right? And what have we learned and what are we going to do? It's disheartening to hear Dick talk about, uphill battles, because tend to be an optimist, and I'm thinking, people have now seen where the cracks are, and we do need to protect from the next pandemic that literally is a flight away, right? As the complexity of why we are having pandemics and why they're going to increase. But I think that there has to be a significant focus on public health.
Dave Self or Dr. Robinson Beal?
Actually, the best points have been made, so I couldn't say it any better than my colleagues have.
Great.
I agree.
Great, excellent. Well, another theme that has come up in the course of the conversation from many of you is the importance of education. Dr. Robinson Beal has spoken about that. I like the quotation from Dave Self, love to learn, but don't necessarily like to be taught. And I'm struck by, here we are at an educational institution, or at least virtually at an educational institution, to think about the volumes of information that are out there on health, the pandemic. What advice, and I'm going to open this one up, we've just got about 5 minutes. What advice do you all have related to this notion of folks taking it on themselves to learn to think about their health responsibly and informing themselves with this information stream that's just constant in through our phones, through the internet, and so on? So I'll open that up. Somebody wants to jump in on advice for our audience on how to advocate and learn about their health and well-being, given all that we see out there that bombards us from media and so forth.
So I'll jump in with that, with some recent studies that I was looking at, where there were a set of assessments done on individuals, and these were people 65 and older. And what they were looking at was their sense of resiliency, their sense of not feeling isolated, and also their attitudes towards themselves. There were several different domains that really roll up to that. But what they found was very interesting. Those that had a higher, and what they called this set of domains, personal determinants of health, those that have higher personal determinants of health had, even though they had chronic illnesses, had lower healthcare costs, meaning that they were not involved in as many hospitalizations and ER visits. And so did more work in looking at that. And these were people who had a tendency to really take care of themselves. These are ones that if something went wrong, they would seek some type of help. It kind of points to, and it implies, it's not conclusive, but it implies that the more an individual is engaged in their own health and they are into protecting their own health, the better off they're going to be, even though they have chronic illnesses that plague our population in general. So it kind of raises a question about self-help and engagement in self-help and long-term outcomes of chronic illnesses.
Thank you. And Dave Self, it looked like you were about to jump in there a moment ago too. So
No, it's a great thing to build on quickly from Dr. Robinson Beal. I'm not smart enough to give advice, but I would just tell folks, don't believe the hype. When you're in a 24/7 news cycle, which we have been since CNN went on the air many years ago, it's a constant steady drumbeat of negative information and sometimes contradicting information. If you're receiving things in your inbox, be smart. If somebody asked you to give your social security number, you probably wouldn't do it. If somebody's telling you that there is some miracle cure for COVID-19, you probably ought to think of it in the same terms. So I really believe applying some common sense, stepping away from the screen, which is kind of weird to say in this forum, but stepping away from the screen for a while and thinking clearly and using those personal determinants of health that Dr. Robinson Beal touched on. Have something that you're passionate about. Take a walk, go out, do the basic things, but don't buy into the hype that it is never going to end. It will, but only if we all participate and take our role seriously.
I think the only thing I would add is, identify what are the trusted sites that you would tend to, gravitate to and really just focus on there. I mean, we're all overloaded with information. We don't know what's fake, what's not fake, so I would urge people to find reputable sites that would help them really discern the best information.
Don't trust Dr. Google.
Well, and as a university, you've got, a health clinic, an excellent health clinic with great resources there. So for a student to find a reliable local source, that's one place to go. And develop a relationship there, because that is that's why that resource is there on campus, and they're available telephonically as well. So finding a face-to-face and then staying with that facility is an important resource.
Yeah, I would add to what Dick just said. Being the university, one that really knows how to look at data, look at research, determine whether or not it's viable, that really puts you in a position to be able to help people to kind of wade through what is fake, what is not fake. I'm not saying absolute, but you can become a trusted source of truth as it relates to things that your student body, your faculty, and the community are dealing with.
Well, thank you. Thank you so much, everyone. We're a minute shy of 12:30. We promised an hour. We might give 30 seconds back to everyone. I so appreciate the expertise you've all shared. We've barely scratched the surface, I know, of your expertise and the issues, but hopefully we've given an interesting hour of conversation around many of the challenges and issues and successes that are coming at us in this healthcare environment. So thanks to each of you. So appreciate your time, and to the audience for engaging and listening. We hope you enjoyed this latest installment of Conviction and Conversation in Contested Times, and we look forward to seeing you at the next one. So thanks, everyone.